Welcome everybody. Welcome to our fourth National Innovation Collaborative event since our birth in very late 2020. And it's great to see the growing interest in these events. We get really good numbers, but more importantly, we get fabulous connections made by everyone that attends. For those who don't know me, I'm Breed O'Brien. I'm the Deputy Director of Digital Health at NHSX. And me and my team have the privilege to work with lots of people on this call and delivering the regional scale programme, which is supported by our Innovation Collaborative. And I'm co-chairing the event today with my colleague Laura, who I'm just going to hand over to, because our Innovation Collaborative is a partnership between NHSX and the AHSN network. Laura.
Hi, good morning everybody. My name's Laura Rooney. I'm Director of Strategy at Health Innovation Manchester. We're part of the National Academic Health Science Network, and as Breed says, we're a delivery partner for the Innovation Collaborative to support the sharing of learning, the best practice across England.
Laura, do you want to keep going on the agenda or?
Sure. Yeah, no, happy to. So we've got, as Breed said, this is our fourth Innovation Collaborative event, and it's great to see continued interest and so many people attending. So thank you everyone for coming this morning. We've got a really great agenda packed for the next few hours. We'll be starting off with a keynote from Dr. Tim Ferris, who everyone I'm sure will be interested to hear your thoughts, Tim. And then we've got various panel discussions with some of our regional colleagues who are delivering this work on the front line. Then we'll hear from Penny Pereira at the Q initiative to take us through the links between digital and improvement. Then we've got some further regional spotlight presentations from colleagues in the Midlands to take us through 3 projects of where they're deploying tech-enabled care into practice. We'll then hear from people involved in the Innovation Collaborative, both from NHSX and the Academic Health Science Network, about what's to come this year. And then we'll be having a panel discussion with Tara Donnelly and Hugh McCorney from also talking about the links between digital and improvement agenda. And lastly, please, if you could hang on for our Slido session at the end, we're really keen to build on insights from the event to inform future work. So thank you. Next slide, please. So what's made these events really special in the past is a huge amount of audience participation and interaction. So please feel free to post comments, questions, reflections in the chat and engage and connect with each other. You also will have time at the end of each session for you to pose questions to our panelists or speakers. So that's really made these events special. So please continue to do that. We've also got a hashtag NHSInnovCollab. If you could tweet away, always helpful to spread the word through social media. And then just a couple of housekeeping items. If you could keep mics and cameras off unless you're speaking. And if you could avoid, if we can avoid any overt product placement or marketing in the chat, that would be really helpful, because this event is geared towards health and care staff and delivery of tech-enabled care into practice rather than promoting any products. We will be using Slido at the end, so if you can have your smartphones ready to take a link into the QR code. And don't forget, you can turn on live captions if you go to more options on Microsoft Teams, which is the 3 dots just at the top. So it's really great to see so many people joining and continue to join in the event. And we are recording, so we will be publishing this on Future NHS for those who cannot come today. Okay, fantastic. Next slide, please.
Okay, I'm just going to quickly remind, so for people who haven't been to one of these events before, I just want to quickly remind you of the vision for our Innovation Collaborative, which is to foster a learning and support system to enable all our teams across the NHS and care sector to rapidly connect, to learn from each other, to share successes, and actually sometimes more importantly, the valuable learning from challenges. And in doing so, to raise the ambition to co-design solutions with staff and citizens to scale digitally enabled care at home. And I'm delighted, you know, over 205,000 people have been supported to date, and that's a number that's constantly rising. We've got over 1,200 people who've joined the NHS Future site, and again, actively sharing And thanks to our innovative colleagues who are on the call, we've got 70 platforms being used across England to support remote monitoring across the 4 areas of long-term condition management, annual physical health checks in mental health, working with the care sector, particularly remote monitoring in care homes, and through our tech-enabled virtual wards, which we'll hear more about through our panel. So really important work, and thank you all for your contributions to this. Next slide, please. So as I've said many times before, this is about improvement enabled by the technology, and there is a theme through the session today about this. And we just thought it was useful to just show an example of if you look at this through the quadruple aim. So really thinking about the areas of impact across those 4 really important parameters of improved provider experience, improved patient outcomes, and I'm delighted we've got Barry as a patient joining our panel later to talk about how it's felt for him, improved patient experience, and the lower cost of care, because we have to work within a value for money concept. So this is a really, these are early learning from individual sites about benefits they have seen. And I've no doubt Tim will touch on evaluation later, but it's really important that we constantly assess the impact of what we're doing. But I'm going to pass over to Tim now, because I'm sure you're waiting to hear from him. I'm delighted Tim could join us. Tim is the National Director of Transformation, and he's going to share his thoughts on transformation and new models of care. Tim.
Oh, terrific. Breed, thanks for the introduction. And I'm really honored to be here with you this morning. You know, this is it's so great to see this intersection and to know that you've been doing this for a while now, that the intersection of the AHSNs and the NHSX and the digital with Hugh McCaughey's improvement all coming together, because I'll get to this right at the end of my remarks, but it is actually at the intersection of the improvement methodologies, digital structures and enablement, and innovation that will be the engine that addresses the NHS's highest and biggest challenges. And that is the pandemic recovery and our capacity issues, as well as the health inequalities that the pandemic has shined a spotlight on. And so I just want to say it is it's terrific to see this joined up work, and I am going to do everything I can to increase the amount of joined up work. So have us working together more, less in individual silos, and more working together to address this country's biggest health needs. So on our priorities, so it's most important for those who are creating and interested in innovation and change to understand what the highest priorities are so they can focus their efforts on those. And there are lots of different ways of saying this, but I'll boil it down to just 2, which is recovery and inequalities. So on the recovery side, you know, I don't have to, everyone is on this call is very familiar with the recovery issues, but I do want to just go back a little bit historically and say that the capacity issues within the NHS have been simmering for quite some time. Actually, it's been well known that the volume of referrals from primary care into secondary care were starting to back up. It was well known that in the winters, it's called winter pressures, right? That the hospitals filled up with medical patients, and that forced the cancellation of elective surgical procedures. So every spring, and increasingly over the years, there was a backlog of elective surgeries that then were worked through during the summertime, only to be built up again during the following winter. But you add the pandemic to that, and the pandemic highlighted several things. And probably most importantly, is that the hospital congestion has become much more severe, to the point where the hospital congestion for medical patients last August and September was worse than in any previous winter, highlighting the significant stress that the hospital bed capacity was under in this country. That in turn was actually and continues to create a backup in emergency, but both conveyances from ambulances and in the emergency room, which itself has created some critical incident situations across this country. This is not a good situation, right? Now, there's a whole lot of thinking that's been going on and needs to continue to go on about how to address this situation. Of course, there are some structural things, just creating more hospital beds, and there are efforts to do that. But but those are relatively long-term solutions. And I think the audience in this forum is going to be with me in thinking, you know, this is actually an opportunity. It's an opportunity because of this pressure. It's an opportunity for us to figure out how to do things differently, how to do them better. And you're going to be spending the day today speaking a lot about home hospital program. The home hospital program, or hospital at home, or virtual wards, or anyone, OPAT, all of those, everything that you can do outside the hospital safely and effectively for patients. If you can demonstrate that what you're doing for that patient is actually reducing the pressure on the hospital, then you've done two things simultaneously. You've provided more comfort and care to patients who honestly would prefer not to be in the hospital appropriately, and to very high satisfaction. I did start and run several hospital at home programs in the United States before coming here, and so I'm very familiar with the extraordinary patient satisfaction that these programs have. You know, I'd much rather be at home with my family, with my family's cooking, and comfortably in my own bed, than in a hospital if I could possibly avoid it. I think all of you would share that. The question is, how do you do that in a way that is certainly effective and safe? So you have to be careful about how you do it, but it's very doable. It's done in countries around the world, and it's been happening in this country at a very low level for years. Recent efforts over the past couple of years, Breed and her team have really expanded it, but there is so much more opportunity to expand it. So that's on recovery. I want to say a couple other words about recovery, so I'll leave that aside for the moment because you're going to spend a lot of time talking about it today. But just say, to me, one of the most important transformative things we can do with the infrastructure in the NHS is to do a better job connecting all the people who are caring for patients so that they are all literally working off of the same page. But here I mean web page or EPR and not paper page. I've worked in a system where when social care, secondary care, and primary care are literally working off of the same page, how extraordinary that is in reducing the friction associated with the delivery of care, that everyone providing a service to the patient is working off of the same page. And as I spend every Friday going around this great country, and the excitement generated by the nurses, physicians, allied health workers, when they can see what the other one is doing, and they show me those platforms, and they're really excited about it because often it's new. It's relatively recently that they're able to see what their colleagues are doing. But I will say most of the systems I've seen are pretty clunky. It doesn't work seamlessly or frictionlessly across those different, traditionally organized silos of primary care, secondary care, and social care. We will be trying more and more to join them up. And the more joined up they are, the more continuity our patients will experience, or the citizens will experience, and the less friction in getting things done. And I want to say a word about the inequality side of this. Last Friday, I had the good fortune to visit the Jean Bishop Integrated Care Center in Hull. And apologies to all of you where I visited or have not yet visited. Whenever you call out one, you're immediately not calling out everyone else. But I'll just say that was my most recent visit, so I'm going to focus on them because they're top of mind. And I just want to say it was brilliant what I saw there. And let me just describe what they're doing to address both the recovery crisis and health inequalities. They are using data to identify the highest risk patients. They are then doing a comprehensive assessment at the Jean Bishop Center or in the patient's home virtually, and creating a management plan that delivers them the services they need, not creating new services, but just connecting them to existing services, and providing those people with an acute care alternative. This is done in tight collaboration with the local GPs, with local secondary care, the local emergency room, local police and fire, and ambulance conveyances. And in fact, they've reduced conveyances because if it's one of their enrollees, the ambulance will call them. They'll work out a solution to the patient's problem without conveyance to the ED. This was exactly the kind of integrated care we need. Now, their IT systems they had aspirations for better. They were doing well, but could get better. So I just wanted to highlight that as sort of moving upstream, and moving upstream in the care process is going to both address our recovery efforts by reducing the need for hospital beds, but also addressing health inequalities. So it was really impressive to see what they're doing. And I know I've seen lots of other impressive examples around the country, so I just highlight that one. And then I'll just finish up by saying all of this work has a lot of challenges. Our digital infrastructure is not where it needs to be. We still have about a third of trusts in this country don't have an EPR, or have a semblance of an EPR, but not a true EPR. It's really hard to do all this transformative work with data if the information isn't digitized to begin with. And so I'm picking up now on the expression from NHSX, which I rather like, which is digitize, connect, and transform. And while it doesn't always happen like in that order, those are three things we need to do. And so on we do need to digitize more, and we have a big effort underway to level up the EPR base in this country. The second thing on that list is connect. Lots of great efforts on connecting, but just in the service of the delivery of care, we have this huge opportunity now to connect across an ICS. And so it says, what is an APR? And I think I should be saying EPR, so I apologize if I said APR, but it may just be my American accent. We call them EHRs in the US, so I'm still tripping over the use of EPR. So on the Connect front, lots of great efforts on connecting, but there is so much more we could do. And that's a whole topic in and of itself, so I won't go there. But we need to do more, and we will do more to connect so that the people delivering care and the people organizing the delivery of care have access to the data they need, the patient care record data for delivering care, and the extracted planning and performance information. And that leads me to my last point, which is for effective transformation, you have to actually measure the extent to which you are succeeding at the quadruple aim. So I love the fact that Breed and others, Laura, that you started off with that quadruple aim, because you have to keep coming back to that and say, are we actually fulfilling our goals with, for example, a home hospital virtual wards on that? And it's actually, just because you put a service in place and you are satisfying patients doesn't mean you're actually addressing all of the quadruple aim. And I've seen time and time again where you put a service in place, patients love it, providers love it, but you're actually adding service. You are not, in fact, replacing service. And we need to make sure that we are substituting more customized, lower cost services for cookie cutter hospital-based services, because that is the only way we're going to get out of this capacity crisis. So, and that is a non-trivial challenge that will require real-time data that allows us to compare ourselves across this country. So we have a huge opportunity here, but we're not there yet. So I really look forward to going on this journey with you. Thank you for inviting me to speak. I apologize that I can't stay. Actually, I have to go to a board meeting right now. But best wishes for your day today. And I really look forward to hearing the summary. So thanks, Breed.
Thanks, Tim. That's really helpful and lots of food for thought. And I think it fits nicely into the thread of the day. So we'll definitely brief you on how it all goes.
Thank you.
Thanks. So now I'd like to welcome our panel. If they could come on camera, that would be really helpful, and perhaps others could go off camera just so you're looking at the panel. I think we've got we just need Barry, perhaps. So for many of you, you'll know that since the inception of the Regional Scale Programme and the Innovation Collaborative, you've been working on virtual wards. So some of the people on this call, what you're going to hear discussed now, because we've moved from what was local initiatives to regional scale to now what is a national initiative, and you've contributed to that. So we've got a really great panel, and I'm going to go to them in turn and ask them to introduce themselves and give you some insight into what they're doing in this space at the moment. I'm going to go first to Steph because she can give us the big picture from a national perspective. Steph, over to you. If you'd introduce yourself and just say a little bit about what your role.
Thanks very much, Breed. It is really fabulous to be here today, and what a fantastic audience. I'm really excited to get into a discussion about virtual wards. So I just look like I froze there, but I think I'm okay. So yeah, really, we've got a new national programme on virtual wards, but it very much builds on the work of the regional scale programme over the last year and brings together work to develop virtual ward pathways in NHSEI with the tech based development of virtual wards and remote monitoring that we've seen over the last year. And our objective with this national programme is to support systems to scale and spread virtual wards. And as Tim said earlier, really to measure and evaluate impact so we can build and extend that model. And as Tim said, that's really important given the amount of funding that we have. That's £500 million over 2 years to sort of really transform the way that we deliver acute care, essentially. And ultimately, our objective is to provide care closer to home with the equivalent, if not better, outcomes for patients that Tim alluded to. But also, it's vital for recovery, right? We see this as a critical way to extend acute capacity, but it has to be in that safe and sustainable way. Just wanted to say that this programme is not about the very fast rollout of COVID virtual wards that we've seen over the winter. This is a 2-year programme that should build on existing services and integrate with them. And, you know, we know that there's some amazing pioneering work on virtual wards happening across the country. So this is about supporting scale and spread, but the ambition is significant. In the operating guidance published in December, we're working to a national ambition of 40 to 50 virtual ward beds per 100,000 of the population. So that's scaling of the order of 3 to 5 times where we are now, depending on where you are. So it's a significant transformation in the way we deliver acute care. And just before I hand back to Breed, you know, that definition is really important. We are, with virtual wards, talking about the replication of acute hospital bed capacity at home. We're not talking about long-term management conditions of home, and that's really important to get the benefits of extending capacity. And we're also supporting 2 distinct types of virtual wards as well. So through the regional scale programme, we've been supporting the tech-enabled virtual wards with which are fundamentally, there's remote monitoring, consultant oversight, but perhaps little face-to-face care at home. But with this programme, we're also supporting hospital at home type models for patients with more complex conditions such as frailty, where you see a blended approach of face-to-face support at home, IV therapies, etc., care assessments at home with digital. So our programme supports both those models, and as a minimum, we're asking systems to implement, you know, 2 kind of key user cases for acute respiratory infections and frailty, where we see huge benefits for a significant cohort of patients. But, you know, this is just the beginning, and we really want to work with systems on their pioneering work to introduce new pathways, and we'll be seeking your help to kind of develop and scale those models. So thanks very much for letting me kick off. I'm really looking forward to hearing from the others about actually how you do this on the ground.
Thanks, Steph. And it's suffice to say there's a lot of support being put into this, isn't there, from a national recognising the importance. Barry, I'm particularly delighted to be able to welcome you today. Do you want to just take a few moments to tell us about what being a patient on a virtual ward meant to you, and what you would like the people trying to do this to hear?
Yeah, good morning, everyone. My experience on the virtual ward was I'd got support from my nurse, healthcare nurse. My family was very sort of confident that if anything happened to me, they knew that they could contact her or them, because I had 2, and it gave us very good, like I say, confidence in knowing that everything was going to be okay when I came out of hospital, because I spent a month in hospital. And you're in hospital, and all you have to do is sit there and eat your meals and take your tablets. When you come home, I felt it was a sort of being pushed out the door, and that was it, sort of thing. But when I started on the telehealth programme, it was brilliant, absolutely fantastic for me.
And thank you, Barry. And you know, some people worry about leaving hospital and maybe the safety they feel in hospital. How did that feel to you? Was it different?
It was the same when I left hospital. As I say, all you have to do in hospital is eat your meals and take your medication. When you come home, I had a raft of medication to take every day, and it was, to be fair, it was a shock. It was a real shock for me. But I knew that I'd got the heart specialist nurse who I could contact, and to be fair, I contacted her more than my GP. If I had an issue, I would ring them, and they would ring me. I remember one Saturday, I was sitting in the conservatory reading the paper Saturday afternoon, and the heart nurse rang me, and she said, one of your data that you put in was quite high. How are you feeling? And I said, fantastic, you know. So it's very reassuring.
Thanks, Barry. That's really good to hear, and I know that we'll come back to for some questions later. I'm going to now go to Vin, and Vin, if you can introduce yourself, but giving us a regional perspective on what this means and the opportunities and challenges.
Thanks, Breed. So I'm Vin de Walker. I'm the Regional Medical Director for London, but I'm also a consultant paediatrician by background. So if I just start really by making 3 points. So one is about 10 years ago, I had to have a period of leave. And when I came back, my colleagues had got together and they'd set up a virtual ward for acute general paediatric patients. And my reflection of them working in that system was, honestly, when you went round and spoke to parents and children and young people, and you said to them, you can go home, but the clinical team will come out, they'll see you, they'll take their observations and they'll feed back. And the consultant's still in charge, so we'll do this as a ward round every day, but virtually. They would sit there and they'd say, can you really do that, doctor? And so absolutely, the patient experience, even 10 years ago, before a lot of the technology was available, the human element of doing this was still, which shows you the potential that we've got building on a really strong historical base. The second piece just to reflect on, of course, is that it's not just that your best, the best bed is your own bed. It's not in a hospital bed. Over 65% of patients in hospital beds in the country are over 65. And for every 10 days that someone over 80 spends in a hospital bed, they lose 10% of their body weight. 10% of their body weight in just 10 days. So I think what we're doing here today, and as part of this programme and what Steph's doing and what we're getting to, there's a moral purpose behind it. There's an economic case and there's a technical case for it. There's a clinical outcomes case, but it's a moral case as well. So that would be the first point I'd make. That's what really motivates me. So the second bit in London is we currently have about 400 virtual ward beds, which isn't anywhere near the national ambition. But there's a huge degree of clinical enthusiasm for the programme, and they're confident that we can get there. But only about half of those beds have actually got patients in. And my reflection as a clinician is that, firstly, there was a kind of workforce element to this that my team report back that we know in London and that I experienced myself. So we need not just enough workforce, but we need to have their skills. We need accurate clinical pathways. They need to be backed up by feedback, data, evidence. And if I'm absolutely honest, the biggest barrier I'm often quoted is clinical confidence in the virtual ward. It took me about 3 months before I felt really confident, and then I was its biggest advocate. So we've got to work through that human element, the clinical governance elements as well. And then the final point, Breed, if I could just make, this is about the technical component of this. So there are over 20 different products now in virtual wards in London. So London's got 9 million people. We've got 5 integrated care systems. There's at least 4 to 5 products currently used in different London systems. Of those, only 5 of them are interoperable with current clinical systems. That's in primary care and in secondary care. Now, of course, as Tim mentioned, as a clinician, I want all the information to be available at the point of care. In London, we have a fully integrated care record at the point of care that integrates health data across primary and secondary care, and increasingly is bringing in social care data. But a lot of the data that we're collecting from the virtual ward isn't easy to load into the systems. It's possible, but it's complex. And so I think over the next few years, we're going to have to agree on a platform strategy. We're going to have a strategy for consolidation. But I think we also need to be clear that doesn't mean we're going to lose space for innovation. This is a fast moving sector, particularly technically, and we do need a methodology for allowing innovation and change as well. So thanks, Breed, and thank you for inviting me. It's great to hear your story, Barry. Thank you.
Thank you.
Thank you. Thank you. And last but definitely not least, we're going to Bushra, who's going to tell us about the Greater Manchester experience and what you're doing.
Thank you, Breed, and thank you, everybody. So my name's Bushra Alam. I'm an acute physician at Salford Royal. I also lead the Greater Manchester COVID oximetry at home, COVID virtual wards, and our new programme, which we're really excited about, which is our virtual hospital across Greater Manchester. So we're an established ICS, and we came together as an ICS to set up the oximetry at home and the COVID virtual ward programme. And we have a really good programme across our ICS. We meet regularly on a weekly or a fortnightly basis to discuss how we implement the oximetry at home and the COVID virtual ward, and now our new programme, which is the Greater Manchester Hospital. That collaborative approach that we've had has enabled us to create a safe space where people can come together, clinicians, operational managers, anyone delivering virtual care can come together into that safe space and be able to share and learn from each other. And we found that sharing and that learning together from each other has really helped us to establish our pathways at great pace. We've been able to share challenges, and we're able to problem solve together as well. So at the moment, we've got our current health bid, which has enabled us to buy 400 virtual care beds across our ICS. So each locality, there's 10 localities in Greater Manchester, will have 40 virtual care beds. And these virtual care beds are to enable us to discharge patients from hospital earlier in their clinical trajectory. So patients who may otherwise have stayed in hospital for a further 1 or 2 days whilst they step down from IV antibiotics to oral, or whilst the clinicians monitored an improvement in their clinical symptoms, these patients hopefully will be able to go home with this enhanced remote monitoring that we have. And we're in the process of setting that up. What we hope is our virtual care beds that we have in each locality, we want to link them into our existing community resources. So our community diagnostic hubs, which we've set up, should be able to help facilitate any patient who might require blood tests. And we also hope to link into existing community services, community nurses and hospital at home programs that we have. So we're really excited about this new project, and we really feel that this project will enable us to free up hospital capacity, to empower patients like James to feel more comfortable, Barry, to feel more comfortable at home, to be in their own environment while still receiving care, and also to empower our clinicians to be able to discharge patients more safely back home earlier in their clinical trajectory and free up much needed capacity. We don't know what's around the corner. We don't know when the next wave is going to come. We don't know what this winter is going to bring. So we've really accelerated and mobilised that pace to develop this as quickly as we can, getting ourselves ready for what comes next, unfortunately, in this pandemic.
Thanks, Bushra. It's great to hear the different views at different levels in the system and from a patient perspective, and lots of questions in the chat that we're not going to get through all of, but we will make a commitment to answer questions offline. And I'm going to go through a couple of questions and give you forewarning. Ben, there's a question for you about what gave you the confidence after 3 months, so we can come back to that. Bushra, for you, I know you've done some work on inequalities, and there's a question about digital poverty, but maybe how you're dealing to ensure nobody's negatively impacted. That might be helpful if you could perhaps comment on that. And for you, Steph, there's a question about workforce. Where's the workforce coming from? And I know you've been doing lots of thinking on that, so perhaps we can come to that. But Barry, just is there anything you'd like to comment on what you've heard from the other 3 people on the panel?
For me, it gave me and my family confidence to know that when I left hospital, which was a massive shock for me, a month in hospital, to know that I could contact somebody and they would sort everything out for me, or if my medication wanted altering, I knew that they would sort it out for me. They would contact the consultant, and now I've got the confidence to self-medicate with my diuretics. My diuretics give me gout, so now I can alter my diuretics, to suit my sort of situation, really, which I wouldn't have done in the past. And the other major thing for me is I haven't got to ring the doctor, make an appointment, go down to the doctors. I know that, or I knew that I could just contact my heart nurse, and she would sort it out for me, which was
great. That's a perfect segue to Vin then. So we've Barry's told us what made him confident. Vin, what made you confident on the other side as a clinician? Oh, you're on mute.
Yeah, sorry. So I'll tell you a brief story. So when I was a registrar in the mid-1990s, so way before virtual wards, we once had a patient who was very needy who went home for monitoring at home and for administration actually at that time of antibiotics at home. And that child died at home. And then, of course, after that, everyone was very scared. So I was brought up as a registrar from the mid-1990s saying, never send anybody home until you're absolutely certain that you were safe. And then if you then reflect on, I don't know what Bushra finds, but a lot of us who worked in hospitals very rarely go and work in community-based settings. And so our attitude to risk is very different. So often if you talk to GPs or consultants who work in the community or nurses who work in the community, physios, they say your attitude to risk in the hospitals is so much lower than ours. You know, you won't send anybody home. So I think being aware and spending some time working in out of hospital settings certainly helped me. The third bit was, of course, we had really good clinical governance. So unlike the mid-90s example where it was the first time we'd ever done it, we'd really thought about this. We'd thought about the workforce. We thought about the pathways. We had an audit system in place. And I still went round and did a ward round on the virtual ward patients every day. So I knew who those patients were and was getting real-time feedback. And then the final thing was clinical pressure. So when I first came back from leave and stopped sending, you know, I wasn't sending patients home that my colleagues were. They went, you could have sent that patient home, Vin, why didn't you? So I had a feedback loop, but also there was sort of peer pressure, if you like, to actually go ahead and do it. And then, so after about 3 months, I just realised how great it was, both from the patient's perspective. I think the final thing I'll just say that's been again something to do with that moral purpose I thought of at the beginning is if you're a carer, my daughter's a carer, and you know she has to take time off work to care for a relative or someone who's in hospital. A, she doesn't get paid, and B, she has to get the bus to come into the hospital and spend most of her day. So we really shouldn't affect not just the impact on patients, but also the huge impact that it's got on their families and real hardship if we don't go ahead and do this.
Great, thank you. And I realise I'm not chairing terribly well because we are running out a little bit, but I'm going to go to Steph and Bushra for the 2 questions we're prompted, and we will pick up other questions and respond in chat. Don't know who wants to go first. Steph, do you want to go first on the workforce?
Yeah, so I think we're seeing system staff virtual wards in different ways. So we have community-based models where we're seeing staff drawn from some crisis response teams and frailty clinics and district nursing to really look at that cohort of patients who could be looked after in the community rather than in hospital. So it's a reconfiguration of existing teams plus recruitment of some new staff. Granted, recruitment is extremely tight at the moment. And then seeing some really innovative models on sort of the more acute-led side with staff being who are closer to retirement, who don't want to do sort of ward-based work anymore, leading some of this digital work, you know, using some of the consultant support has been described to cover those individuals on virtual wards as well. So a mixed model of new recruits, redeploying staff who might have otherwise retired and using existing staff. So and we're going to be publishing guidance as well to give some indication about how you can staff and what kind of staff you need to support virtual wards as well, coming out at the end of February to help systems start to put together the picture. Thanks.
Yeah, it's a lot of focus on workforce, isn't there? Great, thanks. And Bushra, just the inequality question, and there was also another question appeared in the chat about when people don't have devices, etc. So if you could pick those.
So in terms of inequality, I think Greater Manchester is a very diverse area and an area of considerable poverty. So for us, it was really important to make sure that everybody could be included on our pathways. So if I give the example of an oximetry at home pathway, I remember a colleague of mine saying to a patient who'd come saying to me, this patient's come into ESTEC with a pulse oximeter. I don't know why he's got a pulse oximeter. He can't speak a word of English. And it was his daughter that was inputting the patient's saturations and helping the patient to be able to use technology. So we really do need to think quite laterally and quite widely about how we use our technology and who can be available to help the patient. Patient may not be able to speak English, but there may be family members or carers who can support the patient to be able to use the technology. And this patient was then able to benefit from having the same technology in his home that everybody else was having. So access to technology and being able to think more widely is really important. And I think also thinking about what technology we use. So currently, our new technology uses Bluetooth devices and a patient portal where we can speak to the patient or speak to the carer. And I think that's going to be really helpful in ensuring that we have more patients that are being able to enrol on our system. So the Bluetooth will enable easier connectivity and the patient portal will enable face-to-face conversation with the patient or the carer. So I think we've worked really hard also within the Oximetry at Home programme to make sure that groups of patients, for example, patients that are in mental health hospitals as inpatients, also have access to pulse oximetry. We worked with prisons to make sure they also have access to pulse oximetry. And we worked with in care institutions, eating disorders and care homes to make sure they also had access to pulse oximetry. So I think it's really important to not just think about patients in community or patients that were discharging home, but patients in other inpatient settings that will benefit from having access to care and ensuring they also have equitable access to digital technology going forward.
Great, thank you. There are so many questions in the chat, so I don't know if our panel members have time to just have a look and feel they can respond. That would be brilliant, because unfortunately we've run out of time. But thank you to everybody. Lots of really useful insights. It feels like it's the start of a conversation, but as we know, this is a 2-year programme, so I'm sure we will have many more conversations. And there's lots of questions in the chat about interoperability, and I can say it's top of our agenda. So it's heard loud and clearly from Tim's point and Vin's point about, things flowing and being easy for clinicians. So we've heard that loud and clear, and it's definitely a focus. But thank you very much, and thank you, Barry, for joining us. Please do stay with us if you can. But I'm now going to hand over to Penny. Penny is the Q Initiative Director and the Interim Director of Improvement at the Health Foundation, who's going to speak to us about the 2 worlds of improvement in digital and how we can maximise our opportunities. Over to you, Penny.
Wonderful, thank you. It's a real pleasure to have 15 minutes now to kind of step back, think about how bringing together the worlds of improvement in digital can boost all of our work. So I'm going to speak for around 10 minutes, leaving 5 minutes to hear your thoughts and answer any questions. Next slide. I'll be sharing kind of insights from Q. I'm sure there'll be plenty of Q members here, but for those who haven't come across it, Q is an initiative of over 4,500 people from all sorts of different backgrounds who are coming together to share, learn and collaborate as they work to improve health and care in the UK and Ireland. Next slide. So during the pandemic, we surveyed over 200 Q members and we asked them what they thought the top priorities for the improvement world were, given the learning that we've had from the pandemic. Introducing kind of digital innovations effectively came out in the top 2 responses. So I guess there's lots of appetite in the improvement world for engaging better with digital. And I think a sense amongst those of us who carry a kind of improvement toolkit around of what improvement methods and approaches can offer. I think as Breed captures here in this great quote, it's quite hard to think of a service improvement work without a digital element at the moment. And likewise, hard to think of digital implementation work that couldn't have its own prospects for success enhanced through improvement. And yet, we're currently often operating separately. So I guess Q is here as a kind of cross-sector, cross-discipline community that tries to boost the reach and impact of other networks. When we see a silo that's holding us back, we try and support the community to get on in there and reach across divides. Next slide, please. So I'm going to draw mainly on 3 areas of work in this presentation. So during the pandemic, we followed 50 people implementing video consultations and distilled what they learned into blogs and this infographic. Since the autumn, our Q Lab has been working on a project looking at how to boost the trust and confidence of patients and staff in tech-enabled remote monitoring. And our funding programme, QXChange, has seen many projects with collaboration across digital and improvement come through. Our latest round that's just been launched will be focusing squarely on this, and I'll say a little bit more about that in a bit. Next slide. So, in a slide, what does an improvement lens bring into focus when it comes to digital change work, and how can improvement mindsets and methods support success? I've drawn out 4 core processes where I think improvement can help. Just before I get into that, let me just say a few words about what's in the centre there. Next slide. So I've chosen the words fast, credible and sustainable carefully, and I mean them here as I think improvers typically will, in a very people-centred way. So the Q Lab project focuses on what will build staff and patient confidence in tech-enabled remote monitoring, because the level of confidence a project attracts, I think, is a pretty good leading indicator of whether digital solutions are on track. And you'll all know that without the people using and delivering services being involved on side, progress is rarely fast. And even if things are implemented quickly, the seams start to show and service solutions are rarely sustainable. So the change you're proposing being credible is key. But I guess securing staff and patient confidence is far from straightforward. The images here are just a selection from kind of sense-making stage of the current Q Lab project, looking at the map of different factors that influence confidence. The factors individually, I'm sure, will be familiar to you, like strategic alignment, issue of workload, confidence in the reliability of the tech, and attitudes to data security and risk, as Vin was touching on. It's familiar from the panel conversation. And yet I reflect we rarely have the time to think about how these different factors interact and what it would actually take to address them systematically. So while some of what's being learned through this Q Lab project will be specific to tech-enabled remote monitoring, much may well apply to other changes that you could be involved in. So please do kind of follow the work to learn more. The team is kind of sharing as they go through design into testing and practice through the spring. Next slide, please. So we know there's lots involved in the kind of process of change in human systems, but in a few minutes that we have here, I've had a go at drawing out 4 things that I think can help if you want to more reliably get to what you're trying to achieve. So this is based on what we're seeing from the many projects with a digital element that have surfaced through Q and builds on the Health Foundation's long heritage of learning about improvement. So aligning to organisation and system priorities. It's something that we know is necessary if service improvement or technology projects are to get the support that they need. An improvement lens can help take a system view, making sure that the benefits of the technology are understood in a way that's embedded in a wider view of services and needs, rather than the technology becoming maybe a bit too centre stage in how you're describing it. I think this perspective helps make projects credible for decision makers and all the many people who will typically then need to contribute or change for technology to work in practice. The skills of meaningful co-design and collaboration are then needed to follow through on that kind of shared priority. So whether that's involving service users and carers in design of services, mapping supporting processes with those who are going to actually be doing the work, I think improvers can help make sure that projects are really grounded by the perspectives of those who will be delivering and receiving the services in practice. The ethos of improvement, of like rapid testing and adaptation, I think that connects really well with the user-centered design approaches that I know are really well established in the digital world, a kind of helpful counterbalance to some of that overly drawn out approach to introducing IT systems in a big bang way that I think we've learned carries a kind of high risk of failure. Ultimately, the successful delivery of the projects that you're involved in need a kind of whole range of skills, from information governance and project management to role design, process mapping, change management, like much, much more. Complex change needs what they're kind of calling in Scotland a multidisciplinary transformation team. I think improvers can both bring some of the inputs a digital change project team needs and can often bring tools and experience with making the most of different skills and perspectives so that the team as a whole functions well. Certainly in Q, we're finding that these skills of enabling effective collaboration are as kind of central to improvement work as any of the more classic capacity and demand, process mapping or measurement skills that you might associate with improvement science. Next slide, please. So we've learned that, the next, yeah, thank you. I guess, you know, we've picked up that effective teamwork and collaboration, it doesn't just happen. Often the expertise and the hard work involved is under-recognised in the health system. In Q, we've responded with quite a few tools that you might find helpful, from kind of quick processes you can use to make your discussions more genuinely inclusive of the perspectives that you need, to a kind of deeper analysis of the skills and mindsets that are required for collaborative change to be effective. So this map was developed with Nesta as a set of practical exercises that you can use to help pay attention to how you need to work together. Just as the technology is only part of the service change we want to see, so the process of implementing change is, as they say in improvement circles, 20% about the technical aspects of change and 80% human. That doesn't mean that the human bits are kind of simply intuitive or left to chance. It's just that you need to have approaches and skills on your project team that draw on which are kind of appropriately people-centred, and recognise that it's often those people sides of change that will make or break it. Next slide, please. So often it can be quite difficult to get dedicated resources for those kind of people, processes, aspects of change, or for projects that allow us to think more broadly about the change we're trying to achieve, with kind of mechanisms for learning over time and between places. QXChange, which is the participatory funding programme that we run in Q, that's here to complement some of the other offers that are out there. So this year, jointly funded by the Health Foundation and the NHS in partnership for digital health and care. It's all about this theme of bringing together the worlds and methods of improvement and digital. The process is designed to be developmental, help people use their time well, collaborating with others, drawing in ideas from elsewhere. So you can be confident that your project is building on what others know and have already done. We expect to make 40k awards to 20 teams, and those will be selected by the Q community through an online vote. These awards may be relatively small compared to some of the other offers out there in the digital space. However, this funding can be used to bolster existing programmes of work, can be spent on the change process, not just the tech. For example, helping to boost the design or evaluation activity that you're doing, so that we're kind of investing in sustainability, sharing and scaling in a way that I know can be really hard for people to prioritise otherwise. We're also inviting bids here that are about building kind of links and understanding between those working in improvement and digital. So I guess I'm hoping that you, as leaders of digital innovation, might have ideas that you think could be contenders for funding, and could get in touch with Q members in your area if you're not already one, to seed some proposals. And that you might get involved in the process as ideas are shared, so that we can make the most of what you know to shape upcoming projects, because you never know what you might kind of pick up in that process. Okay, next slide. Okay, so that's where I wanted to end, with a kind of practical opportunity for us to build on the things that we're talking about today, whether that's QXChange, the Q lab work and resources, or making links with the people and other work in Q. I do hope that you might find something there that's useful to the amazing work that you're doing. And if you haven't joined yet, you might want to consider it. So yeah, very happy to answer any questions. Love to hear your thoughts or any connections this has sparked for you.
Great, thanks, Penny. You know, I always get excited about when people are talking about the worlds of digital and improvement, because I just think they need to be as one. A couple of things. Somebody's popped a question in the chat, but they've used the acronym FDI, which I have to say I don't know. So perhaps if that person could just write what FDI means, but it says, can QXChange support FDI to gather the evidence and work with the NHS? So we'll wait for that. But question from me, if my advice to people would be go and find your Q member in your local system. But actually, if people on this call who don't know about Q and you've now enlightened them, how would they find out about who their local Q member is?
So there is a publicly searchable directory on the Q website. I can see my colleagues from the Q team have been posting some stuff in the chat, so I'm sure they'll do that shortly. Yeah. You can search by organisation, by name, by HSN area. So yeah, please do kind of take a browse, have a look, see who's around. And you'll see a load of people from all sorts of different backgrounds there. So I tend to think it's a good inspiration to have a chat to somebody, and then you never know, you might find it's also for you.
Yes, and I think it is about, you know, going and having a coffee with your improvement colleague, because they'll have a different perspective. And actually, what improvement people tell me is actually they'd like more interaction and real conversation with their digital colleagues. So I think there's a real opportunity here. I'm just trying to check if the acronym has been foreign direct investment. So I'm glad it wasn't one I've come across before, because I thought, so I think we might have to take that one offline, but we will respond to that. Any other questions for Penny? This question for how can we join Q, but I think your team have been very responsive. I mean,
I love your emphasis on just go and have a chat and have a coffee. I mean, I'm conscious, you know, Tim starts the day with this big vision for joining up innovation, improvement and digital stuff. I mean, that is going to happen through individual relationships and conversations and sense making. So I think we're really here to just try and help with some of those connections.
Exactly. And I think it's you know, what's happened in previous events, this is our fourth event, is people have made connections across the country, across their own projects, but perhaps we also need to help people to know who locally that might be able to help, because I'm often amazed about the people don't know who might be able to help locally. So yes, do look up that Q community list, and for any Q members on here, do make sure you're having a chat to your digital counterparts. I don't think there's any further questions, Penny, and I think that's because your team have been posting so much that all the information is on there, which is great. So thank you very much. And hopefully
just one question I saw come in, which might be worth picking up and answering. Yes, Q is open to people working in anywhere in the health sector. So we have a lot of patient leaders who are Q members, clinicians, managers, people working in social care. It really is open to anybody from different backgrounds who's got some kind of experience in a systematic approach to making health or care better.
And also the care sector, because we'll probably have a lot of care sector colleagues. So great, wonderful. Thank you very much. We're now going to go for till 10:10, thereabouts, for a quick break to stretch your legs and grab a brew, and then Laura will be taking us through the second part of the session, so do stay with us. But go top up your teacups and we'll see you at 10 past. Thank you.
Okay, I think we'll be ready to start, and great to see so many people still with us for the second half of the event. I mean, we've got a tough act to follow, building on what's gone before, but I'm pretty confident with our next set of speakers we'll be able to achieve that. So welcome back, everybody. So this next session is going to focus on 3 projects taking place in the Midlands, and we're going to hear from a range of colleagues who are involved in deployment of remote monitoring solutions in care homes, where we'll be joined by Dr. Qureshi and Roma Holland. We've got Alison Shaw in Leicester, who will be talking about remote monitoring to support long-term conditions, and a project looking at deployment of ECG and mental health services. We'll be hearing from Harinder Kaur and Lexi Island. So each speaker is just going to take it in turn for 10 minutes, and then we will come back for a panel discussion with everybody at the end. So we'll be picking up comments and queries through the chat, so please continue to use that, and we'll be taking notes to sort of ask our panelists questions at the end. So I think is our first speaker on. We've got Dr. Qureshi and Roma. Are you with us both? Yeah? Excellent.
Yeah, we're
If
here.
you're not
Thank
speaking,
you.
would you mind just putting your cameras off just so we can see both of your lovely faces? Excellent.
Okay, thank you. And am I going to do my own slides then?
We'll advance them for you if you would just want to say next slide.
Okay, right, next slide then, please. Right. Thank you. Dr. Qureshi, our GP programme lead, Sue Jacobs, our project manager, and Ian Flowerday from Dockerbow, and I myself, Roma Holland, would like to present to you our learnings from the implementation of our Dockerbow system. In this slide, and the slides will be shared afterwards, so I'm going to go through them at pace. In this slide, you will see the programme leadership team identified the frameworks which were the backdrop of our programme and also helped us identify what our deliverables were going to be. As you'll see here, the purpose was to deliver on the Enhanced Care Home DES, also to deliver on the investment in the Impact Fund, the Ageing Well framework. Our biggest goal of all was to make sure that we'd got system integration. So our clinical system for GPs was EMIS. So we needed to ensure that in actual fact, the Dockerbow solution for our remote monitoring was going to integrate into that system. Next slide, please. The 4 pillars of Ageing Well framework really helped us to identify which system services would have the greatest benefits from using this technology, provided the direction of travel, and it also helped us determine what the outcomes and the key performance indicators would be for the delivery of this programme. Next slide. The governance structure provided the system-wide assurances, and it also allowed us to identify the key stakeholders that were also going to benefit from this programme. The appointment of a GP as a system programme leader was a game changer for us because it allowed the PCNCDs the knowledge that somebody who understood their work pressures, understood what benefits that they were looking for their patient, really they trusted this person who was going to lead on the programme. Likewise, we appointed in as our senior responsible officer someone from the local authorities because that helped the programme influence the contracts for the programme itself. Next slide. We established as part of the governance task and finish groups by work stream, but also that allowed us to develop those task and finish groups at place and on a PCM basis. This allowed the ownership and the culture change to take place actually at the work face. Next slide. Dockerbow offered us animation tools which really helped us provide the care homes and their relatives with actually what developments the Dockerbow remote monitoring ward round could provide to their residents in the care homes itself. It also enabled us to integrate the remote monitoring into our GP overall strategy, and it also allowed us to articulate in our data privacy impact assessments exactly where the data flow was going. So we had a full governance overview of the programme. Next slide. The other thing we greatly learned on was by having a strategy plan for the implementation allowed us to really plan and do the trajectory on where the kit was going to go. It also helped us engage with those PCNs so that actually they could see where the deliverable was taking place across their areas. We've now got the remaining 21-22 plan there at the bottom of that slide. And then later on, I'll show you where we're going into 22-23. Next slide. The care escalation flowchart was designed and will be used across the system. We found that using a standard approach will help us deliver against this programme. This flowchart is also supported by a triage algorithm, which is used in our clinical hubs. Some of you will call those the ICC or the ICE-bar. And what we've now done is use them to monitor the alerts as they're coming in as opposed to the GP practice. I will show you the benefits shortly as to what we gained by using that method and approach. Next slide. Again, we've used animation to be able to articulate to the care home staff as part of the engagement where the benefits would come for them, be it proactive or reactive care. We've also used this in our learning disabilities, and as you can imagine, using something that's pictorial has been a great benefit to the residents so that they themselves can understand why they're participating or being asked to participate on this programme. Next slide, please. An evaluation framework has enabled us to communicate the benefits to the boards and to the primary care commissioning committees. Using the framework has helped us now start to look at where we're going in 23-24. So we're using these benefits to go into the service specifications for the contracts, and that's been a great advantage. Next slide. As a provider of this remote virtual ward round service for the care home, we have identified the system benefits. Again, this has helped us be able to communicate back to the key stakeholders where we are seeing the change within the pathway of the patient, and also it's helping us now to map out where the changes in the system will take place so that we can move the workforce resource or funding to be able to support this programme as we go from project to business as usual. That has been a great help, and that will really help us going forward be able to start looking at the commissioning elements of where the funding needs to be moved. Next slide, please. This Docabo informatic has been a great help, not only in our learning disabilities and care homes, but we're now going to use this for our PPG engagement and our Health Watch Board engagement. Our evaluations have clearly indicated that actually we need to start now getting the patient voice. It's the right time for us to now start participating with those patient voice committees so that actually we take the communities with us on this journey, and we actually do a holistic culture change across the whole system. We've also realised that as a programme, we need dedicated comms within the programme to actually make sure that we are using all of the different approaches of communication. So we are getting key messages out there and people are seeing the benefits that this service is now providing. Next slide. To date, these achievements are only interim achievements with the care homes that we've currently got on, but already you can see that 88% of the notification alerts that go through to the clinical hub are responded within 2 hours, therefore achieving the Ageing Well target. Further digging into where what's happened to the other 12% has indicated that actually we need dedicated phones, mobile phones, to go into the care homes. So when the alerts go off, we have a direct emergency line, a bit like the red bat phone, for us to contact the care home so that we can actually take actions. 100% of the GPs, the PCNCDs, have all stated that they believe using the remote monitoring service is something that they are confident is delivering improved outcomes to their patients. Next slide. Our next steps for 22-23 are to scale up the rollout. Our experience has now told us that we can compress that rollout from 12 weeks to 8 weeks, so we'll get bigger traction. We need to develop a training team, and we've already started to appoint in 12 link workers who will be there to support the care home staff and the staff in the learning disabilities. Also, like the other speakers that you've heard today, we're also doing a hospital at home and we're doing long-term conditions. So these support workers will help do the training and develop our patients to be able to manage the technology. The other part of this is we've also worked now with the University of Warwick, and we're taking on research fellows, and they're taking research studies using this remote monitoring. So we're looking at getting some publication into it as well. And our GP IT fellows are very interested and also doing their research projects on this programme. Now, I'd like to hand over to Lucy, who will put our video on here. And again, Docobo were very encouraging for us to use videos to get messages across, very similar to what we've heard from Barry this morning, because actually that is the greatest confidence builder that you're going in the right direction. So Lucy, could I ask you to put on our champion Mary, who I'd just like to say is 94 years of age, and she is demonstrating that actually even at 94 you can use technology, and she got all the benefits that Barry described earlier on.
I must say, the service I'm getting is absolutely brilliant. Doc at Home is an absolutely amazing idea, and it's made me feel so much more safe is the word, I think. And anyone I've had involved with them, the nurses and everything, they are the most lovely people. So don't anyone ever be worried about not using them. It's the best thing that's ever happened.
Thank you so much both for that fantastic presentation. We're going to be joined now by Alison Shaw. Alison, are you with us? Are you able to pop on the screen?
Yes, hello.
Thank you, Alison. Lovely. You're going to take us through now your project in Leicestershire Partnership. Thank you.
Yeah, so good morning. My name's Alison Shaw, and I'm the lead for the respiratory team in Leicester, Leicestershire and Rutland. We have the next slide, please. So a little bit about us. We're a community-based team of approximately 15 respiratory specialist nurses and physiotherapists. We're a consultant-led integrated team supporting patients remotely across Leicester. We're closely linked to the Acute Trust and have developed a really good relationship with the hospital team. And we work together and we hold weekly MDTs. When we initially discuss with patients about digital monitoring, we ensure that they understand that technology isn't a replacement for face-to-face patient contact, but it simply supports patient care delivery in a new way. During the pandemic, we actually found that a lot of patients preferred to be monitored this way rather than having the face-to-face contact, bearing in mind the vulnerability of our patient group. The clinician will agree the frequency for inputting the data with the patient, and this can be 2 to 3 times a week, depending on how stable that patient is. And during an exacerbation, for example, they can be monitored daily, and then this can be reduced back down again following the exacerbation, back down to 2 or 3 times a week. Each patient has their own individualised care plans, which is fundamental, and their vital signs, the parameters can be adjusted and tailored for each patient's needs. We support our patients to use technology and ensure that all patients are considered for this monitoring. It's available for all patients who wish to use it, and we've never made any assumptions as to which patients can or can't use it. Some patients in their 50s struggle to use technology, and then we have some patients in their 80s who you might expect would be less familiar with using technology and devices, but they tend to manage really, really well. So we're an inclusive service, not an exclusive service. One patient that we had, he'd never used a smartphone or a tablet. It was an elderly patient, and they were shown how to use the tablet and began inputting the digital monitoring data. And they got on so well with it that they decided to buy their own tablet. And then they were able to keep in contact with family during the lockdown via WhatsApp. So it just, it's fantastic. It just goes to show you that you're never too old to learn to use this technology. We can show family and friends how to use the technology to assist patients as well if it's needed. For example, if there's a language barrier or dexterity issues or sight impairment. And we can visit patients as well, set them up at home with the technology, and they also have access to the digital company for any IT support. There's information for the patients there's information modules for education around exacerbation management and breathlessness, and patients are shown these and they have access to these at any time that they want to. They can contact their clinicians by sending a message on the device or calling in. And there's also a video function which is ideal for checking patients' inhaler technique, for example. The clinicians can also message the patient as well, for example, asking them to renew their rescue medications for Christmas holidays, bank holidays, and also if they don't need to input over a bank holiday period, they can let the patients know that quite easily. A recent study showed that in Leicester that digital monitoring reduced unscheduled COPD admissions by 67%. And Leicester City CCG amassed a cost saving of £117,500 in 12 months. 96% of patients who have used the digital monitoring reported that they felt confident, knowledgeable and motivated to manage their condition. Feedback generally from patients is so positive. They say that they find the regular monitoring really helps them understand what's normal for them, and when things are not quite right, they have that insight into that. Clinicians will contact patients if they alert on the monitoring, but we sometimes find that patients who have been on it for a while have already started their treatments. They will have increased their salbutamol inhaler use, or they've already started their rescue medication, and that's what we want. We want them to be to have that self management awareness and know their condition and know when to start their treatment, and that's fantastic. They say that they find the regular monitoring supportive and reassuring, knowing that a specialist clinician is keeping an eye on them, basically. Some patients prefer this way of monitoring rather than home visits. It's quick, it's more convenient for some patients to input that data rather than waiting for a home visit or having to attend a clinic appointment. Also, we are able to double check information. If a patient inputs oxygen saturations that are reduced for them, we can then just ring them and ask them to recheck them for us. One patient that we have was referred to us by a GP following frequent exacerbations and short stays in hospital, always requesting rescue antibiotics and steroids. So they were referred to us. We then talked to them about taking part in the digital monitoring, and through that regular inputting and understanding of how to manage their condition, they were able to identify what a true exacerbation was, which did require antibiotics and or steroids, and what was just an off day, which didn't require those. This was then able to the patient to reduce the number of rescue packs that they were ordering, and because their clinician was monitoring them and contacting them if things alerted, it gave that patient that reassurance and support. The patient then went on to sing in their choir, their local choir, on a regular basis, and it was fantastic, and they felt that they got their life back. Finally, other digital services that we have in Leicester are the COVID virtual ward, where we monitor patients closely daily for 14 days. We've also got a digital pulmonary rehab programme for patients who perhaps don't want to attend classes at the minute or can't attend classes but still wish to take part in the programme. And also being developed at the moment is a digital pathway for managing COPD patients who have been immediately discharged from hospital, and this is a supported discharge pathway. Thank you.
Thanks so much, Alison. We'll look forward to speaking with you again after this next presentation. And then lastly, we are joined by Harinder Kaur and Lexi Ireland, who are going to take us through the ECG project.
Hello everyone, I'm Harinder Kaur and I'll let Lexi introduce herself. So my key role has been as a senior programme consultant working over the Midlands region is to deploy tech-enabled solutions. So one of them's been the ECGs and the other tech has been around physical health checks for SMI patients. Lexi, do you want to introduce yourself?
Hi, good morning. I'm Lexi Ireland. I'm Senior Transformation Manager for Mental Health at Coventry and Warwickshire CCG. And as Harinder mentioned, this has been part of our physical health check for SMI patients project.
Thank you. Okay, so overall, what happened was there was a wide distribution of the Cardia 6-led ECG machines. So they were received by all of the Midlands ICSs. And what we're finding at the moment is still quite early days in terms of piloting and deploying the technology. It's more or less being deployed across mental health sites, which is enabling the healthcare trusts to kind of use the 6-led in line with the 12-lead ones, which were already mostly kind of over the Midlands already deployed. So with the 6-led one, what we've kind of done with the pilot is to promote confidence to clinicians. And also integrate them into existing pathways that were already available and kind of being used for the 12-lead. We've taken the opportunity to roll it out in line with the physical health check devices to technology solutions to do the checks for SMI patients. So just a little bit around how we've done it is we've got a network forum that we have on a monthly basis around for physical health checks, and we've got a bit of a dialogue that we use for the ECGs to turn around and share some best practice, how deployment's gone with each system. What we kind of did was quite early was take kind of a collaborative approach to deploy the ECGs because we wanted to avoid each clinical service doing it individually and kind of do it more on a shared level and use things like the DPIA, a standard operating procedure, as a single overall document. But at the same time, we recognise that each system has their own committee sign-off, a template that they might already have within their organisation. So it's kind of given them an overall kind of a version that they can then tailor for their own service. We've had a kind of a mature system over up north, the TCS and Ware Valley's NHS Foundation Trust. So we've used them as kind of how they did it, what was their best practice, how did they engage with their clinicians to get to use the ECGs and kind of sharing a lot of their best practice, which again gives some confidence around how to use the 6-lead versus the 12-lead. Because what we did here is the 12-lead was working well. A few issues in terms of the patient interaction versus what the 6-lead can do, but overall there was quite of a challenge around trying to get it deployed. So another part of what we've done with the forum and kind of offline in terms of collating feedback from systems is what has gone well for them, what challenges have they faced, and we've recognised the themes around it and then try to kind of give some responses back to share experiences and overcome some of those barriers. Next slide, please. So some of the benefits that we've heard from clinicians and staff that have been using the devices, which has been more around from the HCAs, is that previously primary care staff reported a lack of availability in their surgeries in terms of the 12-lead ECGs. So the 6-lead ones are a lot easier and quicker to use and can kind of give them a recognition of if they need to do more with the patient, it gives them a kind of a baseline. The new machines, they kind of sit on the patient's, placed on the patient's knee or the ankle, so it preserves their dignity. And where patients are kind of felt a little bit uncomfortable around exposing themselves, they felt a lot more comfortable with the knee and the ankle use. The results are printed very easily through the actual ECG itself, and also by doing a 6-lead ECG, it also prevents having to get more appointments and getting the patient to come in for a second appointment or do a further referral. But obviously, if it's needed because it's been picked up on the 6th lead, then that's the pathway that the patient does have to follow. They are a lot more portable and compatible, so you can kind of take them out and about, and HCAs have been using them over with the patients' homes and care homes. So on the preference of carrying a smaller machine than a bigger machine has been a preference. Next slide, please. Okay, so this is a little bit around kind of the on the ground, how it's been going, and some of the issues and challenges we've heard from systems. So a lot of it has been around the resources and in staff capacity, but the kind of way we've kind of managed this to share with systems is try to use what you've already got within your 12-lead and get your staff trained up to use the 6-lead ECG instead of trying to get more staff to come in as in recruitment. But also there's been about the interpretation service, like not all staff can read the results. And Lexi will go a little bit more into this, is how that interpretation has worked and how they've used junior doctors to work with the HCAs and the psychiatrists to sign off the ECGs. There's been a lot of queries around the variation between the 12 and the 6-lead. Obviously, the 12-lead gives you a slightly more of a deeper ECG result than a 6-lead, but the 6-lead gives you is kind of designed to be quick and fast. So it gives you a result in 1 minute, and like I said, it kind of sits on the patient's ankle or knee. But the advice we've kind of given to our systems is use both models, and perhaps use the 6 one as a first one, and then if a further it is required, then use the 12-lead. Another issue that we faced was not all HCAs had mobile phones, so they had their own personal phones that they used. But obviously, because with the 6-lead there is the PID information, so a lot of our systems have had to secure mobile phones through their procurement to allow patients staff to have their own mobile phones, but also then protected through IT governance to make sure the data is secured safely. IG, so a lot of systems didn't really have a DPIA, and with the pressures in the pandemic and then the Omicron surge, it wasn't something that systems could just start developing, and this is where we wanted to take on a more of a collaborative approach for them all. So we've got a high-level DPI that is available for systems to tailor and sign it off with their own protocol. A high-level SOP is currently being designed, and that should be available kind of over the next few weeks. In terms of training staff, there's a lot of training material on how to use ECGs, whether it's videos, and there's a lot of material on a page that the NHSX had set up, which is accessible as well. For reporting, we did a bit of a monthly catch up with system leads to kind of receive soft intelligence around how is it going, what are the issues, how well are they being performed and used, and number of patients that are having ECGs, but also around how they're piloting it, just to gather some of that information, which again we share quite nationally through other leads that are doing kind of equivalent role, but also through the network forum that we have monthly in the Midlands. A key challenge that's kind of been hit over the last year, the last couple of years, but even more so recently, was due to the change in the guidance around the vaccination programme. It's about how we can continue with doing ECGs and NSMI work without pausing it, and the importance of it. So we've worked with our systems to kind of keep that momentum going. Okay, next slide, please. This is over to Lexi just to talk through about the local primary care approach that I took in Coventry and Warwickshire.
Thanks, Harinder. So when I've got a bit of an echo. When the offer for the 6-lead ECG machines came up, we were delighted in Coventry and Warwickshire. So our clinicians had highlighted previously that ECGs are essential due to the impact on heart rhythm by some of the antipsychotic medications. Historically, we had few portable machines, but they're really key when delivering health checks remotely, particularly to populations that are harder to reach. So with severe mental illness patients, we're working to address barriers to access, and we understand that for some, a 12-lead ECG creates anxiety, and it means that someone else needs to touch them, they need to remove their clothes, and 6-lead ECGs negate these fears, as Harinder mentioned. You know, being placed on the ankle or knee allows the patient in some instances to do it themselves as well. So we received our ECG devices in July, and it has been a bit of a long road into getting them operational. Our main concerns were about who would sort of read and interpret abnormal results, conscious that any abnormal results detected would require swift attention. So we took some time, held discussions in order to consider the best pathway for patients. Our chief nurse at Coventry and Rugby GP Alliance, who employ our HCA cohort that deliver the annual health checks, agreed to review any abnormal results via secure email and password protected document. We then had another slight hurdle regarding how to use the devices due to PID being stored on the Cardia mobile app. So we had to find funding to purchase mobile phones for our HCAs that are utilising the machines. We had that approved, purchased mobiles. Whilst that was going on, we created a SOP for the ECGs, which was reviewed by board members and approved. We then hit a further hurdle with the mobile phones being set up with our secondary care trust IT system, and they had multiple restrictions on them. That took some time to unblock, but we did use that time to undertake training with staff members on using the devices in the meantime. So we're finally able to implement the devices on the 24th of January 22 by 5 staff members, with each having undertaken an ECG on a patient during their SMI physical health check since then. None of those have yet required any onward referral due to their results, which is positive. It's important to note as well that where our secondary care teams have been using these machines, we're aware that there have been a number of occasions where the readout has suggested an immediate problem, and people have been sent on to A&E following that being reviewed by a consultant within the team. So I think that's probably all from us, but happy to take Q&As if we have time, or later in the event if not.
Super. Thank you so much. Thank you for that. If our panelists could all just come back on screen, we've just got a bit of time for questions. So we've Dr. Qureshi, Roma, Alison and Harinder, Alexi, you just stay on a moment. Is everyone there? Put your cameras on. Thanks. So I've just been monitoring the chat. There's been quite a lot of questions and comments, and maybe if you're able to stay on and just kind of answer some of the specific questions, that would be really helpful. I know some of you have been doing that already, but I'll just go to Dr. Qureshi and Roma. In terms of your deployment into care homes linked with PCN, where did you start? Do you go with the willing? Do you do a small bit in each PCN and allow them to sort of go on to deploy it themselves with a bit of support? Just what's your advice and model of where to start with care homes?
Dr. Qureshi, you answer.
Just trying to unmute, sorry. Right. What we did actually, Laura, was it was initially a PCN-based project, and this was a part of their PCN development plan. But it very quickly became a Warsaw North-wide project with all the PCNs then coming on board. So it started at the PCN as an expression of interest. And then we went into the other areas such as Coventry, Rugby and South Warwickshire, presented the concept and asked for expression of interest. So it initially started as an expression of interest in the PCN that was initially doing the investment, and were willing to trial the concept and share the learning. But as soon as, even before they went live fully, the other PCNs had already started to engage. So it started with 1 and expanded to 5. And then, the word went out and we did presentations and expression of interest. So that's mainly how we started the rollout. But within the PCN, we actually did some intelligence before we started the care home work. If they had an outbreak, if they had issues, we spoke to care homes and picked the ones which were ready to go ahead and trial. And then it needed chopping and changing a little bit because of the COVID outbreak. So it was quite a lot of adaptations and flexibility even during the rollout. So that's how we rolled it out in the area.
Super, thank you. That's really helpful. Alison, your presentation really told us about that patient perspective, and 96% of patients, satisfied with that service and care. I'm interested to know, because you say, patients did prefer the digital first approach. Do you think they would have preferred that approach had it not been a pandemic and a national lockdown? Just interested to see if you think that was a catalyst for patients being comfortable with digital first, or just get your views of that.
I think possibly it had a bit of weight behind it really with the pandemic, but we've been using digital monitoring before the pandemic, and patients have always seen, I think it's quite it's, like I said before, it's convenient for a lot of patients. They don't have to have the visits all the time. Some patients really do want to have that face-to-face contact. Some patients are quite happy to have it be monitored remotely. So I think there's always been that interest from patients to do both really, but I think the pandemic just kind of exacerbated that really. So but yeah, both really.
And just a question, how did you gather that patient feedback? Did you do it through the tool or other means?
Yes, so there's a tool that we used, and friends and family questionnaires that were sent to the patients, and they asked them the questions and whether they'd recommend the service and how they found the service, that kind of thing. So yeah.
Super, thank you. Just to Harinder and Lexi, physical health checks for people with severe mental illness is quite a complicated pathway, isn't it? Because you've got primary care involved, secondary mental health, and how do you go about finding the right patient cohort in amongst all of that? And you said that HCAs do the test. How do they route the data back into whomever the clinical service lead is, be it community mental health or primary care, or is that a work in progress?
So I can probably take that one from a local perspective, Harinder, if that's helpful. So it is very complex area of work, Laura. So we are lucky that we've, over the last couple of years, implemented a model which works between primary and secondary care. We have a team of HCAs that are employed by our local GP alliance, and they work to a lead nurse. So any abnormal results are reported through to the team nurse, and they also have paramedic teams that can review those if needed. In terms of the sort of data flows, the HCAs, there's a contract in place between the secondary care and primary care providers, so that they are able to read into both EMIS and care notes and able to update accordingly across both systems, because obviously there's huge interoperability issues that have been present, and that's kind of our workaround at the moment whilst we're waiting for an integrated care record.
Super, thank you. And then just a final question for all of you really, and we'll go kind of round the group in turn. What do you really want to happen next with your programmes? What's your kind of your next stage, big idea and ambition? If we go to Dr. Qureshi and Roma first.
Well, we're looking to scale up across the whole of Coventry and Warwickshire. So we're already working across Warwickshire into both South Warwickshire and Rugby. We're looking to do some further integration into AccuRx, so that the clinical hubs known as the ICC and ISPAs can use some nudges, etc. We're currently deploying out across long-term conditions, and we've got 148 patients in Warwickshire North who are using Dockerbow in a box for their long-term condition monitoring. We're just about to deploy that out into heart failure, and once we've done the testing there, we lift and shift across the rest of Coventry and Warwickshire. We're already working on the end of life, and we're doing those question sets with the hospices. So we're looking at now getting the integration into the hospices so that they can receive the alerts as well, and then their community palliative care teams can manage the interventions if they are required. We're also now looking to work at doing the the acute trusts and starting to set up the virtual ward rounds within the acute trust. So we'll have like Swift at home, George Eliot at home, and UHCW at home. I was interested to hear this morning about the sort of like from Manchester, the way that they've badged their programme. And I think that's something that we can take from this meeting and look to do something very similar. So we're working at the moment to start doing virtual ward rounds for the acute trusts. That's where we are.
Brilliant. Sounds like you're leaving no stone unturned. Alison, what's the next big thing for you?
So I mentioned it briefly in my presentation, but we're developing a COPD virtual ward for supported discharge. So patients that have been acutely unwell in hospital. We're going to be working with the hospital team to get patients out at home. We will then monitor them daily for 14 days. More of like an enhanced respiratory service, but do that remotely, and obviously visit patients if we need to. So that's in the very near future. And also we're hoping to develop a asthma virtual ward as well, and so that's also in the pipeline at the moment. But yes, we've got the COVID virtual ward that we're running at the minute as well, and the pulmonary rehab digital pathway as well that we're running. So yeah, we're expanding the service.
Fantastic. And last but not least, Harinder and Lexi. So I guess you're kind of looking to bed in and develop this further, notwithstanding the fact that this is a very complicated pathway.
I think it's complex, but also it's a case of we're in a space of doing more tech-enabled solutions to kind of help patients get the best results quick and easy and get them onto the right pathway for treatment, but also prevention. I think that's quite a key area with ECGs as well as with the physical health check. There's nothing worse than receiving technology and it just sits in somebody's, with the pandemic, we've heard it's been sitting in people's garages and all sorts of very odd and strange stories. But it's about us working collaboratively, and where it's already happening nationally is kind of using that best practice to get the clinical side of the pathways with clinicians working with the digital solutions. So I think that's the kind of the big space. But it's definitely the whole innovative area to get people with the right results and get them onto the right pathway quickly.
Fantastic. Well, thank you all so much. Can't really wait to hear what's next with all of your projects, and I think you will be able to find more details about some of these projects on the Future NHS site. But thank you all so much. Okay, up next we're going to hear from Tim, Donna and Oliver, who are our crack team working on the innovation collaborative between NHSX and the AHSN network. If you guys want to come on screen and start, and if anyone else can turn the cameras off, that'd be great.
Thanks, Laura. Much appreciated. I think it's me first, so if we could go next slide. And I guess just to be really clear before I introduce myself, we're doing a bit of the work. The real work is the stuff that Roma and colleagues in the regions are all doing. So I wouldn't want to try and take credit for that incredibly hard work. And I guess from my point of view, and my name's Tim Cullinan. Hi, everyone. I'm the head of delivery in the NHSX digital health team. It's just a huge thank you. I think some of the work that's been described there around challenges overcome in difficult circumstances is really inspirational, so it's much appreciated. I'm just going to a couple of very quick minutes just to talk about our programme going forward into next year. And what we're really looking to do as we move into next year is build on the good work. So there's been loads of sort of hard yards gained, lots of really, really good progress, and we're really keen to sort of learn and share that progress. And Donna will talk more about that in the Innovation Collaborative. And I guess the other bit we really want to continue to build on as we move into next year, and it's come up a couple of times in the chat, is really around our sort of engagement. So making sure that what we're looking at fits really well for local patient needs, fits well for local clinicians, and also carers and people involved in these services. So just to briefly go over our areas, as we move into next year, we're going to have 4 main areas of focus. They're virtual wards, which we've talked about a lot. There's also long-term conditions. And just to be really clear, it's so important that we focus on this as an area. So the virtual wards is really important. It's an area where people would otherwise be in a hospital bed. But we know that supporting people either in the community or their usual place of care with their long-term condition is a really, really key part of our service going forward in all NHS services. So it's not to say that the community managed element isn't important. It's extremely important. It just has a slightly different focus in terms of virtual wards. Care sector is also a key element for us as we move forward, and we've heard some really good examples, as is mental health as well. And in those 4 areas, some of the benefits that we're trying to look at, and these are kind of, I guess, a bit health service driven benefits to an extent, but we know there's really positive patient stories and clinical stories that sit behind them. So we know that in terms of clinical time saving, some of the work with ECGs in the North East and Yorkshire already saved 70 weeks of clinical time, which is fantastic. We've seen A&E reductions of around 20% in some of our care home work in the Mid and South Essex, which again, brilliant work. We've seen non-elective admissions reduced by around 13% in Hampshire. So again, huge work. And our virtual ward work in NNUH in Norfolk has seen an average reduction of around 7 days. So getting people home out of hospital a whole week earlier, which is absolutely fantastic. So yeah, I guess that was all I want to say really. 4 main areas next year. We've got some benefit areas. We want to learn on what we've done. And we want to say a huge thank you for all the mega hard work this year. So it's much appreciated. Thank you. I'll pass to Donna next.
Thank you, Tim. Good morning, everyone. I'm Donna Clements and I work in the digital health team at NHSX, and I've got a focus on shared learning and improvement. So we've heard some great examples this morning of how technology-enabled care and remote monitoring can make a real difference to people's lives. But as we know, some of this technology isn't new. But over the last 18 months, we've seen a real rapid increase in how we use the technology and different uses across pathways. And as Tim Ferris mentioned this morning, this is a real opportunity to do things differently. So it's so important that we share the learning and the different ways of using this technology that can support care away from hospital settings, keeping people where they feel comfortable and safe, i.e. at home, as we've heard through the great examples today. So as you've heard, the Innovation Collaborative is all about sharing opportunities, the challenges, the successes and the learning, so that project teams and frontline staff are not starting with a blank sheet of paper, and they're really gaining the experience and knowledge from other teams who have been there, done that, got the t-shirt. So we'll work together as the Innovation Collaborative to share the impact of technology-enabled care and to really build a library of evidence-based resources that can be used across the health and care systems and people moving towards digital models of care. So as you've seen through the chat this morning, we have a lot of resources that are shared on our Innovation Collaborative workspace, which is hosted on the Future NHS Collaboration platform. And our workspace currently has over 1,200 members, which is rising, which is wonderful. And those are members from health and care sector, academia, voluntary and third sector, as well as digital innovators. We have over 500 shared learning resources on that workspace, which have been downloaded or viewed over 7,000 times. And given this workspace is a little over a year old, we think that's pretty impressive. So the majority of resources on the workspace relate to the focus areas we've heard about this morning, but there's also resources on there that support the role of digital in elective recovery, as well as signposting to other resources for digital health and care. We have resources that include case studies, podcasts, videos that share experiences from staff and patients and service users. So really get that impact across, and those human stories are so important, as well as the quantitative benefits. We've got resources on there to support people working through benefits management. We have recordings on masterclasses and thought leadership events, which include human-centred design in healthcare and inclusive digital transformation. So there's a real range of really useful resources. We will be uploading the recording from this event, and equally we have recordings from previous Innovation Collaborative events if you want to learn about other spotlights from regions that we've talked about. And really importantly, we've got locally developed resources, such as you've heard from today, such as standard operating procedures, DPIAs, onboarding guidance, example of posters that could be used with patients. And we're really, really keen to share that learning from local teams so that you learn from each other. And we're also really keen to explore some of the different improvement methodologies that people are using so that we can share those as well, appreciating that one size doesn't always fit everybody. So if you want to know more, if you want to learn from others, or you want to share local resources and knowledge that you have, please get in touch with us. We'll drop into the chat once again about how to join the workspace. The workspace is only as good as the people who actually can contribute to it. So please help us to get this shared learning across the system, because then we can make a real difference. Okay, that's it from me, and over to Oliver. Thank you.
Thanks, Donna. Thanks, Tim. I'm Oliver Barnes, and I'm the Programme Director for the Innovation Collaborative for Health Innovation Manchester and the Academic Health Science Network. And I'm going to talk to you about how we're going to continue to make a difference through this next phase of the collaborative to June 2022 in generating insights and sharing learning and best practice. So what is that offer? What is that support? And what are the resources that are going to be available? So through a benefits side of things, we have specialist benefits coaches that have been assigned to each ICS who are delivering tech-enabled remote monitoring projects. 39 integrated care systems are being supported to date, with up to 4 days on average of bespoke benefit support. We're going to continue to build change and deepen the evidence base through rapid evaluations, collaborating with clinicians, specialist nurses, tech partners to support vulnerable and at-risk groups in the community. Continuing to tell the story as well through people, process and cultures, and that will entail 2 national events, one of which we're on today, 5 more podcasts, 7 more case studies, a comms toolkit, an animation, 4 more videos, 7 more specialist workshops, and 6 tailored newsletters. And just to reiterate, all these resources will be available on Futures, in addition to the ones that Donna has gone through, and we encourage you to utilise them. They're there to be used and shared and support your learning and implementation.
Okay, super. Thanks everybody for that great overview. And I think there's been lots of links in the chat to how you join Future NHS. I think Dan said we've had quite a few sign-ups off the back of today's event, so that's really great to hear. Thanks everyone. Okay, for our next speaker slot, could I welcome Tara and Hugh, if you're able to share your cameras, take yourselves off mic. Excellent. And you've been busy listening in for the whole event, haven't you? Which is great. So thank you for joining us. Tara, if you wouldn't mind introducing yourself to everybody, and then Hugh.
Sure, happily. And I've been doing a tiny little bit of tweeting as well. We've been going. I'm Tara Donnelly, and I am the Chief Digital Officer at NHSX. My background, though, has been in essentially running hospitals for many years. So I am quite an operational person. And for me, bringing together digital improvement and ops is a real sweet spot. So I've thoroughly enjoyed this morning.
And Hugh, if you wouldn't mind introducing yourself.
Yeah, thanks, Laura. My name's Hugh McCackey. I'm the National Director of Improvement, and a bit like Tara, I've spent the vast majority of my career at the delivery end, probably about 30 years working in trusts. Most of that in Northern Ireland, where we had integrated health and social care trusts, which was a great opportunity, I think, because actually as a chief exec, you were managing the complete spectrum of care, from the hospital right through to care going into people's homes or when people were placed in other forms of care. So it actually was a massive opportunity to be able to span the boundary in a way which, or you were, the boundaries weren't there, which made it a lot easier for implementation. But I suppose just to say, it's been I think it's been a fabulous morning, really exciting, and I love these types of things because that sort of seeing real examples, real case studies, led by people in many cases in the front line, supported by others, and it's, I think the challenges for us is how do we take those innovations and make sure that we embed them in a way where not just the group of patients in that area or in that locality, the people that have done it, but we make it much more widespread. Sorry, somebody showing me my.
A little bit crackly, Hugh. Yeah.
Okay, I'll see if sometimes if I raise the laptop up, it helps. Is that a bit better?
That sounds a bit better. Yeah. Yeah. So maybe just following on from that, Hugh, you know, how we take this best practice and scale. That's exactly what the Innovation Collaborative and the Remote Management Scale programme is there to do. And what's come out from today's event throughout all of the presentations is digital transformation is as much about people, process, culture as it is about the tools and the technology. So what's for both of you your perspectives on how do we align digital and improvement now to harness this sort of best practice and scale it across the country to deliver transformative benefits for patients and citizens? Don't know who wants to go first on that one.
Will I kick off, Tara?
You're very welcome to. Yeah.
Okay. It's funny, as I was listening, I mean, I did find it really stimulating this morning, and I made a huge amount of notes, and which was probably why I wasn't tweeting, Tara, but I will tweet later. But actually, as I started to try and connect it together, I sort of put a number of transitions I think we need to do, and a number of journeys we need to make, I think, to create the future that we want. The first of those, I'll just quickly run through them, but moving from, and what today has been about, moving from hospital to home, you know, moving from a sort of form of institutional care and being able to keep people in their own homes. And, you know, all the stories today, and I would always start with the patient. I think Barry was, you know, for me, I distilled it into the 3 C's, you know, being able to, his concerns about leaving a hospital and going home without having people around him in the care. And those concerns were addressed. Having the confidence that anything he needed out of hospital could be delivered. And then the third C was the continuity that this delivers. So the fabulous example of the heart nurse ringing him up to say, you have one of these results off, and you know, that being so proactive. You know, what was before, when somebody goes home, they're out of sight, we have no idea of how they are. But this continuity, so that we're actually monitoring people in real time, I think is fabulous. But it's shifting from the institution to home. I think there's something around how do we move from more healthcare to better health status, and it's that upstream thing, which is about being more proactive rather than reactive. So shifting from a reactive model where we're treating dependent, or we're sort of interacting when people become dependent, vulnerable or ill, but actually how can we get upstream and keep them well, keep them from becoming dependent, keep them independent. So there's that really being truly proactive. I think to answer one of the answers, the other shifts we need to make answers the question you've just asked me, which is how do we shift from silos and doing national programs, pushing things down in initiatives down into the delivery end, to be much more around how do we collaborate and create integrated packages or integrated initiatives. And I think a key bit of this is moving from programs to pathways. My experience as a provider was, you know, you had somebody coming at you about, you know, initiatives in digital, you had somebody coming at you about, you know, outpatients, you had somebody coming at you about, you know, GIRF, you had somebody coming at you about a NICE, you know, you were getting 130 sort of safety notices a month. You have to sift all those and try and make sense of them and try and find ways to implement them. And the reality is you have a certain bandwidth. The more we can actually embed this into, here is the pathway for these types of conditions. And I think the examples I've just had, you know, from Roma and Alison and Harinder, are actually around how these things are embedded into a pathway, an optimum way of doing something. And that will also help us to scale things. The other shift, I think, is moving from a paternalism, and I think Vin captured this a little bit, where, you know, he talked about, you know, how they being in charge of the patient and how being risk averse But actually, when you move from that sort of the doctor taking the decision to this is something we do in partnership with the patient, it's empowering for everyone, the clinicians and the patient, and the experience is very different as Barry outlined. And I think the sort of couple of last ones that I will promise to finish was what I described as moving from the wildflowers to the ploughed field. The risk, I think, is we have a lot of innovations which sprout up all over the place, but we don't have a systematic way of really making sure that they embed, and that, I think, comes back to the pathways. And we need to be, the opportunities we've heard today, the initiatives we've heard today, imagine if every patient, we could implement that much more quickly so every patient benefited from it in every area. And that's what we've struggled with traditionally in the NHS. So we have to be much more, I think, systematic, and that's where pathways will be a real benefit. And one final thing, which is a sort of shift, which I think is about the culture. We celebrate innovation, and even today is about it's about the innovation collaborative, and that's entirely right. But I think we also need to encourage the behavior of harvesting. So it's back to my ploughed field again. But actually, what we want is people to be hungry to pull these initiatives in. We want a culture. We want to celebrate the culture where people are looking for, the examples we heard from the respiratory team, or in the care homes, or in the ECG initiative, so that people are wanting to pull that in, and that we're celebrating that. Breed talks about the pinch with pride. I think, I love the term, but which Maureen Bisignano coined, was around being harvesters of things that work. If we do that, then we will embed things much more quickly, and our patients will benefit and our staff will benefit.
Thank you for that, Hugh. Lots to pick through there. But Tara, do you want to come in?
Yes, sure. And I couldn't agree more with what Hugh was saying. So this is the 4th event I've been to, and I've so enjoyed the previous ones that I have to say my expectation was completely sky high. And I haven't been disappointed at all, because once again, we're hearing about incredible progress from when we last met. And people are so generous with sharing their practice with others. I would have loved, some of the information that Roma shared on her slides. As a service manager setting up services, I had to start from zero. I remember sometimes ringing people up from an HSJ article because it sounded like they were doing something vaguely similar. But, the friction that involves, tracking people down. Whereas I think this is a community of harvesters sharing their work with such generosity, just to help other people in the NHS do things a little bit more quickly, and not reinvent the wheel, but business cases that people have shared. Some of the most, Donna talked about the 7,000 views and downloads. People are looking at really practical things like benefit cases, business cases, data sharing agreements. Brilliant. Let's just share the heck out of all of that, because we haven't really got time to hang around here. Do find a moment to watch the Mary film. It's fantastic. And I think, as Hugh was saying, the way this feels to people is just amazing personalised care. The tech enables it, but it's not about the tech. It's about the relationship. And as Barry described, he feels like he's looked after all the time. There are 3 nurses looking after over 100 patients like Barry. Yeah. And yet he feels fantastically supported. He's not going to his GP as much. He's not being hospitalised. It's really good all round. And what's great, I think, is that the whole morning has been quite a celebration of some of these terrific stories and the feedback that we're getting from staff and patients alike. And it's now moving into how can we make it even better? The interoperability piece. Do we look at slightly fewer platforms? I have to say that there's been a bit of chat about should we just have one national platform, and I really don't think that's the answer for loads of reasons. But also, it's a mature market, the remote monitoring field. There are different products, and having competition between them will help keep standards really high. But it is the oil, isn't it? The data that we have about our patients is the oil that runs everything. So enabling greater interoperability is definitely a key task, and some people have cracked that really well. And I have to say that all the remote monitoring companies that we have linked into, because they're part of this partnership as well, are completely up for adhering to standards and so on. Sometimes it can be the bigger players who are less keen, but we're also having really strong conversations with them about just making this the right thing for patients. So, and then the final thing I just wanted to make reference to is the scaling. So I was looking recently at the whole system demonstrator, the telehealth research that was done some years ago. They looked after 6,000 patients there. This programme has already got digital home care to 205,000 people in every region across the country. This is scaling. Virtual wards is in an amazing place because it started with some visionary people, some of whom, like Bushra, we've seen today, and it has become an absolute mandated requirement for the NHS in the planning guidance that came out on Christmas Eve with serious money attached. So that is, we are watching something move into the mainstream that will make such an enormous difference to people. Vin talked about the deconditioning point, didn't he? You know, having worked in hospitals for about 30 years, they're great, right? If you're acutely unwell, that's where you need to be. However, they're pretty terrible the rest of the time. So if we can do more to help people recover in the comfort of their own home, but with supervision, that's, as Vin said, a moral challenge, isn't it, to try and achieve that? So they're just a few thoughts from me about the morning. But Hugh.
Yeah, Laura and Tara, I mean, it's almost a challenge to everyone that's on the call. And I used to take a team every year away to the IHI BMJ sort of improvement conference, and one of the things we always did, we made a virtue of, was we would all take some learning back, but we all committed to do at least one action or connect with one other person that we felt could add value to work we're doing. So in a way, I throw out a challenge to everybody that's on the call. It's easy to go away, stimulate and learning, and then bang, you're back into, you know, today's and tomorrow's sort of pressures and work deadlines, etc. So, you know, my challenge would be, don't go away from here without making at least one connection and taking away one thing that you want to use. And whether, I mean, I would encourage people to stick that in the chat box, or even to connect with one other person that you've heard from or that you're going to make a connection with, because it just does that wee bit of rigor, if you like, in terms of forcing ourselves to think about, in all that we've heard today, what are we going to use? Who are we going to connect with? And if we do, each of us, the 280 or 300 people that are on the call, that will increase the connectivity. And it's through that connectivity, that agility of the way we work, that really makes things happen. So I'd encourage people to do that before they finish today.
Absolutely, thanks for that, Hugh. And staying connected through the Innovation Collaborative, you know, because we will be doing more of these events, and you know, Breed's going to kind of sum up some of this towards the end of the session. Just one final question for you both, then, that kind of came through the chat as well, was and building on what you said about taking a pathway approach, Hugh. In order to do that and to really reap the benefits of tech-enabled care, how do you work with clinicians to really identify the problems that need to be solved? Because these things aren't a panacea for everything, are they? So just from using your sort of improvement expertise and you know, tech transformation, how do we get really crisp definition of problems that clinicians are dealing with on a daily basis?
Yeah, I'd go back almost to one of the things Tim said right at the outset, and he mentioned the transformation engine, and at the minute it's very much in the sort of concept or idea stage, but I'd be very keen that we actually have an input from you know, the Innovation Collaborative. I'll be wanting to get sort of an input from the Improvement Directors Network. I think there's a whole range of other people who I think should shape this. But the concept behind it is, how do we take, and that sort of moving away from the silos piece where we're working on a particular issue, there's a digital solution for, we're maybe working on something through a nice recommendation, we're maybe working on something that's come up as an improvement somewhere.
How do we take that into the transformation engine where we take each of those inputs, the digital, the improvement, we have the clinical leads, we have the range of people that we need in there, that everybody has a, an input to make and a contribution to make in that sort of agile way. And they help us redesign the pathway with clinical leaders so that the crispness, as you say, of the problems are embedded into, and what comes out of the transformation engine is a sort of optimum pathway that's saying we should be having the virtual ward, we should be having Roma's sort of connection with care homes, we should be having the ECG deployment in these conditions and pathways. And then all the changes from the different points are embedded into the pathway, and it's the pathway then that we should be implementing. And one final point I did forget to make earlier was reinforcing, and what I really liked about the presentations, each of the presentations, and I made the point in the chat box, they all had assessed impact. And I think that's going to be critical for us moving forward. How do we forget about let's not forget about, but the outputs or the things that we produce, and think, what difference does it make to people's lives? How does it impact on their not just their experience, but their lives? How do we make their lives better? And that's how I think that's the goal in terms of where we need to get to in terms of impact.
Tara.
And just to add a couple of thoughts on that is, one of the ways that the regional scale work has been run has been to have tight elements and loose elements. So the tight bit has been that people have had to commit to uptake to a certain number of patients, because this is about scale. But the loose bit is that they've been given enormous freedom about the best way to do that. One of the things that has been so interesting is to see that where people have put in remote monitoring for perhaps one condition or a virtual ward for COVID or for respiratory patients, as soon as clinicians get these devices in their hands, they can instantly spot new opportunities. And we've seen that. We've seen kind of criteria being set quite narrow, perhaps slightly risk averse to start with. People gain the confidence and then they see the possibilities locally. So I think that's a terrific explosion of innovation. But as Hugh says, we can learn from that, and we can learn from what works really very, very well to say, actually, this ought to become much more the norm. I think we're seeing that a bit in blood pressure monitoring at home, that actually all the evidence is pointing towards that is a better way to manage your health than to be schlepping to a GP regularly. So there may be areas where we think, do you know what, the evidence is so strong here that a bit like, the cancer 2-week wait criteria, we would go that this is the pathway that should be offered to everybody across the country.
Fantastic. We could stay for another hour, I'm sure, talking through all of this. And thank you both for your time, both in terms of this panel session, but also being with us for the whole morning. Everyone's really got a lot out of that, so thank you so much. Breed, I think you're coming on.
Wow, what a great discussion. Thanks to all three of you. Really good, and lots of food for thought. I think I might have written more than you, Hugh. Anyhow, I'm going to give some closing reflections, but firstly, I'm going to introduce Christina, who's going to do a Slido, and this is really important. So please don't just log off and think, oh, it's all over, because we want some feedback on the event, but also we want some inspiration for future events. So over to you, Christina.
Thank you, Breed, and thank you for a really perfect introduction, Hugh and Tara as well, because the next 5 minutes is massively important, and we really need your help in the sense of how we make the most of resources as well as the legacy from this event. So what we'd love you to do, and you might have used Slido before, is if you've got your smartphone at the ready, and if you could scan the hashtag and the QR code, or you could join via just heading to slido.com and entering the code on the bottom right hand side of this screen. This is an opportunity really to get your thoughts on how we shape the products and resources with the Innovation Collaborative that we talked about and that Donna touched on in particular. So future events and activities that we really want to make the most of for you and make sure that they are fit for purpose, and not only for that, as Hugh described, to absolutely make sure that we're making a difference to patients at the end of the day. So we have the resources available. This is going to be 5 minutes, but massively valuable to us in how we take those next resources forward. And the first question we've got, and feel free to start typing away, but maybe in as little words as possible. What is the biggest challenge you're facing right now in effectively deploying new remote monitoring tech? So we've heard on the chat this morning about things like interoperability, workforce staffing, the old chestnut around how we make sure that we're looking at data sharing as well as winning hearts and minds. So this is an opportunity for you to kind of put in about subjects that Breed, the team and the broader team can take forward to think how we can support you best with these challenges. So you can see here there's a lot of things around interoperability and skill mix coming through. Just to say as well, you can also email the collaborative after this session if you think, I didn't say that within this quick fire 2 minutes. But it's lovely to see that we're getting so many thoughts through the power of technology. So we'll just have 1 more minute on this and then we will switch to the other big question before going back to Breed for closing remarks. But please do take this opportunity because we're here to help you in terms of trying to achieve that aim, and we appreciate time is massively precious, not just today, but of course to make sure that we're using time effectively moving forward. So I think we've got 82. If we head to the magic 100, I think we'll switch. Oh no, we've already switched. Fair enough to the team. We're keeping time. So we'll go to the next one. And again, these are really key if we're looking at maybe deep dive events or smaller events for people. What topics and themes do you want to see? So how can we support you in rolling out tech-enabled home care and hearing from hopefully more Barrys and Marys and inspirational people through kind of supporting you with kind of more deep dive events, for instance. So again, inclusivity I can see on that, but it's great that we're seeing patients' experience, agreed. Maybe we should have a Barry and Mary session talking about kind of their challenges and the benefits that they've found. IDs coming up, unsurprisingly. So don't forget, we've got another 7 different events that we can tailor, hopefully, to make sure that we can support you the best we can. And in addition to that, of course, there's loads of resources already on the collaborative site. Please join if you haven't. And also on that one, we're going to put hopefully lots of more inspirational case studies with really good evidence bases and learning for you all. So this again is massively important to make sure we're getting it right for you. We're nearly up to 60 odd. If we can get to that magic 80 again, that would be wonderful. And then there is just 1 more minute of very quick feedback before we head to Breed to kind of close with some remarks about today's wonderful session. And a big thanks again from us in making this happen and joining. It's been brilliant to work with all of the speakers. It's been inspirational. We're nearly at the magic 70, but I think we might switch now. But again, please email us if you've got any thoughts in addition to this. We always love to hear from you. And you can also post in the Future NHS workspace as well if you've joined. There's a good forum there that you can access at any time. So I think, Faye, if it's all right if we then switch to, we've got loads of brilliant feedback. This is a very quick survey. As Breed said, everyone hates surveys, but this is massively important. So just a quick yes, no. Did the event meet your expectations? This is the point where we look between, between fingers. Oh, amazing. Should we just stick with the one person that's put 100%? Brilliant stuff. Thank you. We'll have another couple of seconds on this one. And we'll keep this open for people as well. You can go back at any time and have a quick look. But that's brilliant to hear. And again, we know that we can always do things a little bit better. So even if it's just the look and feel, or whether you want more case studies, less of me wittering, please do feedback. We're really grateful for your thoughts and your input. We're heading nearly to a top 50. It's good to see that there's a high part, but we want to make sure that it's 100% in future. So if we could move on to the next question, that would be great. Thank you. Did you learn something you can apply in practice? As Hugh was saying, this is obviously the $1 million question. If you can take something away and really work on something as part of how you move forward, even if it's connecting with somebody else in the chat, which lots of people have done, which is great to see. And we're all past the magic 60, so it would be brilliant again. Oh, the wondrous word cloud. What is the main thing you'll take away? For me, I think it's probably just it's the patient. That's why we're all here doing what we do, and amazing people from Leicestershire and the Midlands that have spoken today, how they've made an impact. So things like hearing that someone could go back and sing in a choir again was just fantastic, because that's kind of the outcome that we're really wanting to focus on. So what might you take away? Is it that you've got an important contact to follow up? You've got ideas from things like Roma's presentation around how to take some ideas forward. It's really nice to see that collaboration's in the middle. Again, sorry for the sales pitch, but please join. The resources on there are fantastic. It's the best project I've worked in the NHS, having worked for nearly 15 years in digital comms. So collaboration and patient focus, it's great to see that in the middle. And then we've got very last thing, I think we're pretty much any further comments. So I think that might be one to take away. And again, please post into the chat, contact us if you've got any broader thoughts. Very good point about how we do stuff quicker at pace. And again, I think collaboration, it's not rocket science, is key to that, and really getting that balance right between how we work digitally, but also how we work hand in glove with people, and getting that balance right between the physical and the digital. Looking forward to the next one, so are we, and we're going to make it even better. I think we'll give it a couple more minutes, and we'll probably then head over to Breed to make closing remarks. But again, a huge thank you. It's the people that bring the content alive. We're so grateful that you've attended the event and for making time when it's massively busy out there. We appreciate that. So I think, yeah, I'm pleased it is my day job. Thank you very much in that. If I would hand over now to Breed to make some closing comments, but thank you for really valuable input, and do get in touch if we can support you any further.
Great, thanks, Christina. So I'm going to keep it very brief, but I love the fact that we've had about 400 people during the course of the event. So that's really impressive, particularly with the pressure in the system. So thanks to everybody who's joined. Thanks to all our speakers and presenters, and thanks to Christina, Jane, Cheryl, Donna, all the people who've done work in the background that you may not know, but brilliant event. A couple of things that struck me. Love the fact that people say, how do we want to do stuff quicker? Because what I've observed is variations across the country where some people are managing to get that tension between doing stuff quicker but doing it safely. And we need to constantly ask ourselves whether some of the bureaucracy that we naturally seem to have in the NHS adds value, but obviously not compromise safety. So I think that's an ongoing question for ourselves. There's lots of questions on there about business cases and design and stuff. And last year we ran lots of sessions on this, and there's great resources. Everything was recorded on the Future site now, so please go on there and have a look. Really interesting to me. I'm not a feminist, but actually all our presenters from the regions were female. And actually we hear so much about women in digital. There's a real sea change happening here. So well done, ladies, not being exclusive to our men, but that's an interesting observation as someone who's worked in technology and healthcare for many years. I think Barry's points are really valid and really, really important. And hearing them from Barry himself is so powerful. And we try to make a commitment that the patient voice comes first, whether that's real time or as recordings. And colleagues have popped an interview with Lee, who was a patient in the east of England that I interviewed for half an hour, and it's a raw cut of a Zoom chat. But he mentioned well-being so many times in that conversation, and that was well-being from being at home. So thinking about, I read something yesterday about, the mental health impact for people being in hospital. So really thinking about well-being, both physical and mental health. And picking up Vin's point about we've got a moral obligation to do some of this. It's interesting because recently in a conversation, I was speaking to somebody about equality and ensuring that if people couldn't access digital, they weren't negatively impacted. And actually somebody pushed back to me and said, well, hang on a minute, that means they're not getting equal care. So we need to make this available to everyone. So that was an interesting contrary view, because I was always thinking, as long as we make sure people have access to care, whether it's face-to-face or digital, that's the first key point, which it is. But now we're getting to a stage where actually some people think this is is better and they want equal access to it. So that is a real sea change. Really like, I think Hugh, as you said, the shift from reactive to proactive. So really important, we started with virtual wards, but it's that upstream work around long-term condition management, annual physical health checks for patients with serious mental illness who have a 20-year life expectancy, less than others. These are really important things we need to address. And I work with the care sector. So for people for whom home is a care home, let's keep them at home. They have 24-hour care. If we can provide that medical care safely, that's really important, particularly for people with dementia who get disorientated, and coming back to that whole deconditioning point earlier. But most importantly, the thing I'd really like to close on is this is about valuing people's time, and that's patients' people's time. And we've got a lovely clip from someone who has had a long-term condition and is on warfarin as an anticoagulant and has to have lots of blood tests. He can now do all that at home. And he talks about that puts him in control of his illness rather than it controlling him. And that is about valuing time. So measuring value in time is really important for patients, but also workforce is our biggest challenge at the moment. So valuing time for our staff and ensuring we use technology to make life easier. And that comes back to some of the, well, lots of the comments about interoperability. We do need to make this streamlined and work for people. So the right information at the right place, at the right time for anybody delivering or receiving care. And I'm going to finish by saying thank you to everybody for really trying to drive this agenda forward. We will take everything that's come in the chat, all the comments on board, do a synopsis and plan the future events to really respond to what you feel is needed to support you. So big thank you and have a great rest of the day.